Thank you everyone for coming. My name is Dr. Emma George. I'm an Associate Professor at the University of Adelaide and the Program Director for Occupational Therapy. It's my pleasure to be one of your MCs today at the VirtuCare Policy Apprentice Forum. The COVID-19 pandemic dramatically shifted the way we work in many sectors around the world, and healthcare is no exception. During the pandemic, India, like Australia, quickly adopted virtual healthcare in an attempt to provide healthcare to the 1.45 billion people amid strict lockdowns and widespread serious illness due to COVID. However, during this swift digital transformation, the health and rehabilitation needs of people living with disabilities were not always prioritised and adequately considered. In response, the VirtuCare Research Project, led by the University of Melbourne and working with counterparts across Australia and India, has worked to ensure virtual healthcare solutions are inclusive to people living with disabilities. We are excited to share the findings of the VirtuCare Research Project with you today. Over the next hour and a half, we will hear from key program supporters, champions, funders and stakeholders, all of whom have contributed to the deep impact the project has already had. After lunch, we will host a workshop where we will discuss and plan the next steps for VirtuCare. We invite all stakeholders to stay and contribute to the future of the project. Now, without any further ado, let me introduce Professor Michael Wesley, who will formally welcome us to today's VirtuCare Forum. Professor Michael Wesley is the Deputy Vice-Chancellor Global Culture and Engagement at the University of Melbourne. Professor Wesley provides leadership across the universities with overall responsibility for strategic guidance and expert advice on external and global engagement, government and corporate affairs, and the university's cultural estate. He's also Professor of Politics and author of several books focusing on the Australian foreign policy within Asia and the Pacific. The University of Melbourne has been a key partner in this project, so thank you, Michael, for your continued support. And now let me invite Professor Michael Wesley onto the stage for some welcoming remarks.
Emma, thank you for that very warm introduction. Let me begin by acknowledging some VIPs who are on this today. Let me start with Mr. Vikas Trivedi, the Member Secretary to the Rehabilitation India. Now, we are proud of the strong partnership we have under the bilateral MOU on disability between Australia and India. Can I also welcome Minister Councillor Carly Partridge from the Australian High Commission in Delhi. Thank you for your ongoing support. Can I also acknowledge Sri Rajesh Agarwal, IAS Secretary, Department of Empowerment of Persons with Disabilities from the Ministry of Social Justice and Empowerment of the Government of India. Mr. Mohammed Amil from the World Health Organization, Regional Office for Southeast Asia, and Dr. Mohammed Ashil from the WHO Country Office in India. And I also welcome Dr. Sanjay Sood, Project Director of Sanjivani, the National Telemedicine Service, CDAC Mohali. Can I also welcome the Honourable Lisa Singh, CEO of the Australia-India Institute at the University of Melbourne, Professor Nathan Grills, Academic Director India for the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne, and to the entire VirtuCare network and to all of our distinguished guests with us today. We're delighted to welcome you to the second event of our Asia Pacific Outlook series in collaboration with AsiaLink, the Melbourne School of Population and Global Health, and the Australia-India Institute at the University of Melbourne, alongside the broader VirtuCare network. The University of Melbourne aims to play a leading role in interpreting the defining dynamics of events in Asia and the Pacific, as outlined in our global plan, Advancing Melbourne Globally, which we launched earlier this year. With this event series, we aim to provide a foundation to foster debate and create awareness about Australia's place and relationship with the region. Focusing on issues faced by societies of Asia and the Pacific. We are looking forward to bringing together evidence-based discussion to address the specific challenges faced by Asia and the Pacific and to provide focus on solution-oriented outcomes. It is here at the Melbourne Global Centre in Delhi where we invite the global academic community to deepen our engagement and explore opportunities for partnerships and collaboration across teaching, research and community engagement. The VirtuCare project is a reflection of the university's global strategy advancing Melbourne globally. So it is very appropriate that this is the first event of this series that we hold here. Importantly, this initiative provides avenues for greater inclusion, accessibility and progress for individuals with disabilities both here in India and across the globe. To deliver the VirtuCare project, the University of Melbourne brought together expert partners from across Australia and India with the support of the Australian Government through the Australia-India Council. The partners include the Public Health Foundation of India, PRASHO, the George Institute, Monash University, the University of Adelaide, Infosys, the Emmanuel Hospital Association, Mission Accessibility, CBM India, St John's Medical College, and the Centre for Development of Advanced Computing in Mohali, India. Together, these partners have provided evidence-based recommendations and designs for future virtual platforms and policies that address the health and inclusion needs of people with disabilities and the workers who support them. The commitment to the co-design process has led to the training and accreditation of over 1,400 community workers through the community-based inclusive disability course designed and delivered by NOSL and the Government of India. These courses, alongside the development of communities practice and digital platforms that support workers, are fostering healthier, more inclusive and more educated communities. This means that people with disabilities, particularly in rural areas, can access informed and meaningful support. In working towards inclusive future virtual platforms, the VirtuCare network partners focus on the use of technology to envision and implement more inclusive healthcare for people with disabilities. Collaborating with the lead Indian partner, eSanjeevani, a major telehealth platform based at the Centre for Development of Advanced Computing in Mohali, India, they explore avenues for more inclusive and accessible healthcare options for people with disabilities across India. Telehealth is an increasingly critical resource, and eSanjeevani facilitates approximately 450,000 telehealth consultations per day. Partnering with eSanjeevani provides the VirtuCare network with the opportunity to leverage significant data points to inform the development of evidence-based models that can transform the lives of people with disabilities and improve the global standard of healthcare and knowledge. Finally, the VirtuCare network engages in high-level research across the partnership to evaluate programs, explore avenues for success, and make recommendations for the future. The VirtuCare project demonstrates a strong history of partnership and cooperation between Australia and India. Importantly, this collaboration provides a foundation to make a difference for people with disabilities here and globally. Thank you.
Thank you, Professor Michael Mesley, for those excellent welcome remarks, and thank you for hosting us in this beautiful space as well. Up next, we'll hear from Minister Councillor Carly Patridge from the Australian High Commission here in Delhi. Carly has close to 20 years of experience in the Australian public service across multiple agencies, with expertise in designing and implementing policy and programs. She's worked in the Departments of Immigration, Health and Veterans Affairs prior to commencing at the Department of Foreign Affairs and Trade. We are grateful for the continued support by the Australian Government, particularly the Australia-India Council, in the Department of Foreign Affairs and Trade and the Australian High Commission. Thank you, Carly.
Thank you. How's that sound wise? Okay? All right. And thank you, Professor George. And good morning. I'd also like to acknowledge some particular and special guests here today. So, Sri Rajasatvo, Mr. Muhammad Amir, Dr. Muhammad Ashil, of course, Professor Wesley, Dr. Sanjay Silat, Dr. Meenu Singh, the Honourable Singh, the entire VirtuCare network, and it's also a real pleasure this morning to meet Mr. PSG and also Professor May Brills before we started today. Thank you very much. So, of course, I'm really delighted to be here to launch this incredible Melbourne Global Centre in Delhi as part of this VirtuCare project. So, the new centre marks a major milestone for a stronger India-Australia ties. You would know that the India-Australia relationship is booming in all sorts of ways, strategically, economically, and in this incredibly important area of healthcare and education as well. This new centre serves as a hub for academic, community and industry collaboration, fostering deeper partnerships, knowledge sharing, cultural connections between our nations. And so, as a representative of the Australian High Commission, we see this as a really important node in our bilateral relationship and a hugely significant aspect of that. It's also a real pleasure to be able to attend the second event of the Asia and Pacific Outlook series. The inaugural University of Melbourne series provides a vital platform for discussing the evolving dynamics in our region and exploring opportunities for collaboration. This event is the first one to be held outside of Australia, so the fact that it's here in Delhi is really special. We're so proud, Emily and I, from the Australian High Commission, we're so very, very proud that the Australian government can fund this bold project. It builds on cooperation in disability, and that's been facilitated through our bilateral memorandum of understanding for disability cooperation. The outputs of this project seem disproportionately large compared to the initial scope of the work, and some of the numbers that you just talked about were really quite inspiring. Some key highlights of the project include a co-designed research paper. This was a collaboration of Indian and Australian academics, think tankers and government. It outlines 15 recommendations for telehealth in India in relation to governance, education and training, systems approaches to deliver equitable services, interdisciplinary approaches, innovative technological solutions, and intentionally designed telehealth for diversity and equity. And I'm of the understanding that the network's already started working on these. Another highlight includes supporting the Sanjivani, as Professor Wesley just spoke about, to improve their accessibility score to 94%, which I've led to understand is an extremely high score for the scale of the program. The projects focus on meeting with, working with, and designing with people who have lived experience of disability, and that's such an important part of this project. An appropriate and effective design of the program. So, on behalf of the Australian Government, I'd like to congratulate you on these achievements. Disability inclusive development is a priority for Australia. It's an area we've been an active leader in. I reflect on my time in the Department of Health, and that was certainly the case then. We're developing a new disability equity and rights strategy in coming months so that we can continue to be a strong, consistent advocate and indeed a partner to India. We're supportive of the University of Melbourne's work with the Department of Empowerment of People with Disability and the Ministry of Social Justice and Empowerment. I really wish to thank our India collaborators for taking the disability inclusion journey with us, and for Professor Nathan Grills in particular for driving the project so ably. What I want to say is something that I say in a lot of forums that is so important, which is this is a deep partnership where we can learn from each other. There's knowledge sharing on both sides, and as we work together and hold hands towards this incredibly useful goal of equitable and inclusive virtual healthcare for people with disability, which is part of the broader equity and inclusion for society at large. Thanks for allowing me the opportunity to come and celebrate this with you today. Thank you.
Thank you, Minister Councillor Carly Patridge, for those incredibly supportive remarks. I'm Dr. Shailaja Tetali from the Indian Institute of Public Health. I'm the Dean of Research and Policy Support there. I would now like to introduce Dr. Sanjay Sood, who will be presenting some insights from the eSanjeevani. Dr. Sanjay Sood is the Project Director at eSanjeevani, India's state-backed national telemedicine service. He has been a leading figure within the global telemedicine since 2000, having previously served as a telemedicine consultant for WHO, which allowed him to garner implementation experience in other low and middle income countries. Dr. Sood was awarded the Digital India Award from the Honorable President of India in 2020 in recognition of his contributions. And now let me warmly welcome Dr. Sanjay Sood to the stage to present Secretariat insights from eSanjeevani. Welcome.
Thank you, Professor Shelton. Good morning, everybody. At the outset, Professor Michael, Minister Councillor Carly, Professor Nathan and his team, Dr. Professor Meru Sayuk from AIMS, Rishikesh, and Joint Secretary, Mr. Rajari from Government of India. It gives me immense pleasure to talk about eSanjeevani that has revolutionized the healthcare delivery system in the country, or rather increased the access to healthcare services nationwide. We all know that healthcare is the cornerstone for a thriving society, and in a country like India, which is enormous, it is really challenging to provide equitable health access to everybody across the length and breadth of the country. And it is only technology that could have achieved this, or that could have enabled this, or that could have surmounted this challenge. And eSanjeevani is one such, I would say, crown jewel of digital India that has enabled access to health services even in the rural areas and remote communities, population in remote communities as well. eSanjeevani was born as a simple but a profound idea way back in 1999, and Professor Meru Singh, one of the foundational members whose inputs have really gone a long way in shaping eSanjeevani, what eSanjeevani today is, kept on evolving, and currently as the initiative of the Ministry of Health and Family Welfare, it has evolved into the world's largest telemedicine initiative or implementation in primary healthcare. We've already, as Professor Michael mentioned, we've already served close to around 300 million patients, and on an average daily, eSanjeevani is effecting more than 450,000 consultations across the country, and there are over 220,000 healthcare providers, which includes community health officers or health workers, doctors, specialists, super specialists who are serving the populace through this platform. And eSanjeevani has already been enabled at over 127,000 health and wellness centers across the length and breadth of the country. And besides being available to the population in the rural areas, eSanjeevani is also providing health services to the urban populace through online OPDs, which number more than 400 online OPDs across India again. And as far as the other aspects of impact goes, eSanjeevani has been enabled not only in health and wellness centers, but it has also been enabled at the old age homes, orphanages, and prisons as well, which has enabled the access to specialized healthcare services even to the inmates at all these places. And of late, with the inclusion of eSanjeevani in the VirtuCare project, courtesy Professor Nathan and his team, we are fortunate to now we've started focusing on the accessibility aspects of eSanjeevani, and we are thankful to Mission Accessibility as well for sharing their insights and sharing their expertise to help us to scale eSanjeevani up to the next level, where we are targeting to address the needs of specially abled people, and we are leveraging AI and natural language processing, etc. as well, to have the features which will increase the inclusivity of healthcare services across all sections of the populace and the patients in the country. And we've already made it multilingual. eSanjeevani is available in over 13 languages, including English. And we've also tried out proof of concept to have speech-to-speech translation using Bhashini, which is Government of India's latest offering in the multilingual space, addressing the language barriers. And we recently demonstrated to the Honorable Additional Secretary, Ministry of Electronics and IT at CDET Mohali. We could demonstrate that the patient speaking in Hindi could be heard by doctor in English, and similarly, doctor speaking in English could be heard by patient in Hindi. So these kind of speech-to-speech translations we are enabling, and very soon eSanjeevani would be supporting 13 such speech-to-speech translations on the fly. And besides this, we are also trying to incorporate the suggestions or the guidance that is being provided by Mission Accessibility to increase the accessibility aspects of eSanjeevani, like enhancing the user interface, which would enable specially able people to use it as easily as an average user of eSanjeevani uses. And that is not just the end of it, and I'm sure in years to come, eSanjeevani would be seen beyond the Indian borders, and many country governments have already expressed interest in having eSanjeevani being implemented, having eSanjeevani implemented in their countries. These include Fiji, Philippines, Nigeria, and Sri Lanka, etc. And I'm also thankful to the colleagues from WHO's Southeast Asian Region Office and the country office who extended their support in enabling us to ensure that eSanjeevani is again in compliance with the global accessibility standards which have been put in place along with ITU. So we're working closely with them as well, and very soon I'm sure eSanjeevani would be a model platform, telehealth platform, which will pave way for the next generation of telehealth applications. And we are looking forward to the day when it'll be as easily used by especially able people as we are comfortably using it. With that, I thank all the supporters and contributors and stakeholders of eSanjeevani. And before closing, I would like to congratulate Minister Councillor for the yesterday's launch there. And I'm sorry I couldn't make it for some other unforeseen engagements. Congratulations for that. Congratulations, Professor Mega. Thank you very much.
Thanks, Ananda.
Thank you, Dr. Sanjay Sood, for presenting those very important thoughts. I would now like to introduce Professor G.V.S. Murthy and Professor Nathan Grills, who will be providing us with an overview of the VirtuCare project research findings. Professor G.V.S. Murthy is the president of PRASHO, the Pragyan Sustainable Health Outcomes Foundation. He is also a trained epidemiologist with nearly 40 years of experience in public health management and health systems research, specializing in non-communicable diseases, including blindness and disability. He was the lead investigator for the research aspect of this project. Professor Nathan Grills is a public health physician at the Nossal Institute for Global Health, the University of Melbourne, and senior research advisor at the Australia-India Institute. He has spent the last 2 decades researching non-communicable diseases, public health and disability, mainly within community settings in India. Nathan has been an integral part of the project delivery team and has led today's event delivery. I welcome Professor G.V.S. Murthy and Professor Nathan Grills onto the stage to present the VirtuCare project research findings. Right.
Thank you, Shailaja, and I want to add my welcome to the welcomes that have already been said, and just say what a privilege it is to have such a group of people that know this area so well and are experts in this area. But I think I want to say that these group of people that are here are all friends as well. I really enjoyed this collaboration because it's relationship based. I think if I was to go to the first slide, it's working. What I'm most excited about probably is all these logos. It looks very colourful, but it shows the depth of the collaboration and the partners that have been included in this project over the last 2 years. I won't name them all, but there's 16 logos there, so you can try and work out who's who from the logos. But it does show that I think the depth of the program is based on people's expertise, and I think like the Ms. Councillor said, the return on investment has been very good for the Australian High Commission and for DFAT. And it's largely due to the in-kind contribution as well of many of the partners that see this area as a really important area to work on and don't require lots of funding but have a lot of passion that drives them. What was launched was back into 2022, and the Honourable Barry O'Farrell was the High Commissioner at that point from Australia in Delhi, who opened or launched the VirtuCare project. So it's been 2 years, but a lot has happened in that time. And I think, as we said before, the use of technology has expanded so rapidly in the last 5 or 6 years, particularly since the pandemic begun. But it's good to see after the pandemic has stabilised that there's still a real desire to continue to use telehealth, virtual healthcare to provide healthcare to the most marginalised and people who are in isolated areas and people with disabilities. So I'll go back one slide, sorry, Nick. So the VirtuCare project investigates how we can use technology to promote access to health and to disability care in India. There were three main aims that we had as part of the project. To assess the extent to which VirtuCare healthcare services met the needs of people with disabilities, to identify ways to enhance access to telemedicine in India for people with disabilities, and then finally to use the technology to equip community-level disability workers to be able to provide disability care at the community level. I'll come back to that in a second. Next slide. So they started out with a scoping review, which was a really useful process to start to see what was already happening in the Indian context. So we're looking at the usage of telehealth in India to see how it had been used in the disability space and looking at what barriers have been identified in being able to provide telehealth to people with disabilities. And we also identified approaches that could be used to make it more accessible. So looked at ways that could actually help improve the telehealth network in India. So the recommendations that the Minister Council referred to, there's 15 of them. I won't go through the 15 of them, but these are four that we worked very closely on over the last 2 years. I think we've made significant progress in all of these 4 areas. So promoting interdisciplinary collaboration between government, non-government, technology and telecommunication companies to promote inclusive health. That's evidenced, I think, by the number of partners that are here. That collaboration has been a really important part of setting this agenda forward. Capturing disaggregated data on the use of telehealth services by people with disability. That's been something that's happened during the project. We had an opportunity to be able to gather large amounts of data on the usage of telehealth in India, and my colleague will speak about that in a minute. And improve the interface of telehealth apps like eSanjeevani, and looking at how we can maximise its use for people with disability. And finally, the recommendation that we have been able to work on was fostering localised approaches to virtual healthcare to enhance accessibility and tailoring communication to specific cultural contexts. So next slide. So I'm going to focus on that recommendation at the very end there, looking at how do we get telehealth services to the margins, and also how do we help equip workers in the disability space in rural, remote parts of India. So this is based on a project that's been very close to my heart, and to acknowledge Sri Rajesh Agarwal, who's the Secretary of the Department of Empowerment of People with Disability, and Mr. Vikas Trivedi, who's the Secretary of the Rehabilitation Council of India. They've been very central in this project. It's a community-based disability inclusion workers, which the department and the Rehabilitation Council has facilitated training of these workers. I work in rural North India, and seeing the workers on the ground make a difference has been really important. What we found though is it's very difficult for these workers when they're in an isolated space to be able to be equipped and supported to be able to deliver disability care and disability services. And so we've been trying to work with these workers on the ground to understand what their needs are and how we can best use use digital technology to support them in how they go about their work. So there's a lot of these workers now next year we're hoping to train about 3,000 workers across India. They're called Divyang Matra, or CBID workers, community-based disability inclusion workers. So we want to look at how we can develop technology to support them. We did a pilot of this program in North India, in Uttarakhand, and we came up with a program called Parola, which it allowed us to have a community of practice where peer-to-peer support was available to help people workers in the community to get access to answers to questions or to share ideas and to use or learn in an ongoing way after they finish the 6-month course. So Dr. Lloyd Reshma and Martin here who have been involved in that course, so we'll hear more about that this afternoon. Now also they've been developing tele-rehabilitation resources like videos, which is will be as part of an app that we've been working with, which is available to all the community-based inclusive development workers to use to facilitate their work in the field. As Dr. Sood suggested, the scale of eSanjeevani is just something else. I can't get my head around doing 450,000 consults every day. That's just massive. So it's a privilege to work with eSanjeevani to make sure that all those consults are disability inclusive. As part of that process, we work with Mission Accessibility to do a disability accessibility audit of the eSanjeevani platform, with eSanjeevani being a part of that process. And yeah, it scored 84% initially, which is still a very good score, I think. There's people here that could probably tell me how high it is, but there's still space for improvement. But eSanjeevani, on the back of that audit that we did last year, committed to try and raise their accessibility level to 94%. I think they recently said just go to 100%. So it's great that they made changes already. Some changes are easy to make, some changes will take some time. A number of people in the audience here are involved in that process from SIDAC Mohali in trying to make the interface accessible for people with disabilities. So look forward to getting close to 100% maybe by next year. I want to hand over to a colleague now, GPS Murty, who's a part of the idea behind this whole program and who Melbourne University has worked closely with since 2012, I think, and various research projects. And it's a privilege to have GPS as part of this research project.
Okay. I'll pass the mic on to you. It's a very conversation.
Thank you, Nathan. Thank you, Shailaja. So I'll try and look at what work we did in addition to what has already been mentioned by Nathan. And we were looking at how is the use of teleconsult facility, how is it being used by people with disabilities? So those are the research questions. To what extent has virtual healthcare met the needs of persons with disabilities, as well as how can we strengthen the services so that there is a better use of persons with disabilities using telehealth facilities. And have the next slide, please. So there were two phases to this. The first phase was in relation to the stakeholder interviews, finding out what the stakeholders felt about having a facility which could be enabling for persons with disability. And this was conducted both with people with disabilities and with stakeholders who were managing institutions or organizations which are looking at services for people with disabilities. So that was an important aspect to gather in-depth information. And the second was with other stakeholder interviews. These are the healthcare providers, how they felt or perceived of how services should be provided for people with disabilities, and gathering that evidence to make these services more inclusive. Next slide, please. So in both those phases, we had very similar themes. So one was accessibility of services, and whether it was person with disability or the stakeholders who were providers of services, which included services of person with disability, the accessibility, the availability, the acceptability of the platforms on which these consults could be provided, the quality or the perceived quality of the services, and the affordability of services. So these are the five major themes that were tried to be that the evidence was tried to be gathered amongst the two groups. Next slide, please. Then the next aspect that we also looked at was a great opportunity with the eSanjeevani platform. And this was to try and look at how is eSanjeevani being used by persons with disabilities. What is the sort of uptake of services from the eSanjeevani by persons with disabilities. And this is something which would be a game changer if we are able to look at the benefits that such a portal actually provides. Next slide. So here our research questions that we looked at was what is the overall proportion of people with disabilities using the eSanjeevani platform, and whether the persons with disability who are using the eSanjeevani platform, what are the specific type of healthcare problems or conditions that they were using the portal for, whether there was a difference in terms of the social demographic characteristics, the age of the users of eSanjeevani, the sex mix and the rural-urban mix of people with disabilities, and what was the range of disabilities amongst the users of eSanjeevani. Next slide. This is a busy slide, and therefore I'll just try to give you the overall theme. We had about 55 million users of eSanjeevani during that specific period when we looked at a 6-month period, during which period we had 7,000 people whose disability status was looked at from what we call the Washington Group questionnaire. Difficulty in hearing, seeing, mobility, etc. Which means that out of those 55 million consults, less than 0.01% were people with disabilities. So there is an opportunity. They have started using it, but there is an opportunity for further increasing it. When we look at the types of disabilities, there were differences between gender, in the use, and also in terms of the age. We find that though disability is more concentrated at the older age groups, all disabilities, in terms of the use of the system, it is basically the younger population which is using eSanjeevani. And therefore again that is an opportunity as to how we can enhance the utility of a platform like eSanjeevani for the older populations who actually have a higher prevalence of disability. Next slide. Once again, when you look at within the age brackets, there are significant differences by gender and significant differences by age. But like I said, the younger age group is using it more, where the requirement is higher amongst the older populations. And that is something which we need to look at as to how we can leverage the power of a consultation process like this for persons with disabilities. Next slide. So we'll have a panel later which will look at the way forward. I've spoken about some of those gaps, and those gaps are easily bridgeable. There is no difficulty, but we need to see how we can improve the access to take this forward. Thank you, and over to Shailesh.
Thank you, Professor D.V.S. Murthy and Professor Nathan Grills, for providing such a comprehensive review of VirtuCare's research findings. It's been such a pleasure working with you both on this project, as well as with the other organizations and stakeholders. I would now like to introduce the 4 members of today's panel discussing the way forward for VirtuCare. You're already familiar with Dr. Sanjay Sood, so let me go ahead and introduce the panel's next member. Dr. Meenu Singh is the current Executive Director and CEO of AIIMS, All India Institute of Medical Sciences, Rishikesh, and she's the President of Telemedicine Society of India. She specializes in asthma, tuberculosis, and cystic fibrosis in children, and is a pioneer of evidence-based child health within India. having previously led the Advanced Center for Evidence-Based Time Health. The next member of our panel is Mr. Amar Jain from Mission Accessibility. Amar is a lawyer practicing in the areas of corporate law and disability rights. He is also a certified professional in web accessibility, allowing him to consult for and train people in website accessibility to help facilitate access for those with disabilities. He has led the accessibility audit of the eSanjeevani platform. Our final panel member is Dr. Joseph Sunny. He is the director of Prayatna, an interprofessional pediatric clinic in Cochin, providing occupational therapy, speech therapy, and language therapy, as well as psychology and physiotherapy and special education. He is also the secretary of the All India Occupational Therapy Association. Finally, this panel will be moderated by Dr. Uman John, a physician and public health researcher with special interest in health informatics, including the strengthening of health systems via disruptive innovation. He is the country lead of Health Systems Design, Data and Insights at the Bill and Melinda Gates Foundation. He has helpfully advised VirtuCare and linked it to the health system here in India. I now welcome the four panelists and our moderator to begin their panel, please. Thank you.
Hello everyone. It's a pleasure to be here. When a small introduction before going to the panel. So at the time when we were designing this project, I had 6 visions. But along the project, my vision rapidly increased. So I have been in a position where I have to use a lot of technological tools to get around with my day-to-day living. And that's given me an inside perspective for what it means for platforms like eSanjeevani to be inclusive. So I'll start my question with Dr. Meenu Singh. What potential does virtual healthcare delivery pose to benefit people who are otherwise excluded by our current platforms?
So we know that during COVID time, we had upcoming of eSanjeevani, although we were trying to iteratively design along with the CDAC Mohali, which Dr. Sanjay Sood led development of this software, and it has such a breakthrough after that. And has been shown by Murthy also that during that period, there's a large number of disabled people who accessed eSanjeevani. And so this is certainly a wonderful platform which can be used for access for people with disability, for making them included into the social development and for looking into that kind of perspective. I think we have several of these aspects which can be looked at by innovation and then also evaluation of various techniques and technologies that are being used for making certain interventions for people with disability. And some of these interventions, we know there is an early intervention centers which are being built for children who are graduating from neonatal intensive care units. Many of these kids are still exposed to developing cerebral palsy. Some of them would also develop visual impairment because of retinopathy or prematurity. Some of them do have auditory defects. They are deaf because of exposure to high levels of bilirubin. So many of these are certainly preventable conditions which can be handled by giving care to their mothers when they are in the antenatal period. And in states like Uttarakhand, where I'm working right now, we find that the access to healthcare is very meager. And so much so that our infant mortality rate is higher than the national average. So what we need to do is to make these interventions, and especially platforms like eSanjeevani, available, maybe in a hub and spoke model, which we created in the state of Haryana, where it's being very successful. and a large number of people are benefiting from that. So that is one area of prevention of disability and doing early interventions when they are upcoming during the childhood age. And of course, later on, there are so many things which we are coming across in the Uttarakhand, that is, we are exposed to so many accidents which happen in the higher reaches of the state. And people lose limbs, people lose lives, but they also lose limbs. And because of that, they are disabled. And we are just going to establish an LMO-sponsored center in our institute for giving them artificial limbs. But we are also looking at developing something like a bionic limbs, maybe feet or hand or lower limb, upper limb, so that they can be self-enabled. I really hate to say that we do want that the wheelchairs should become extinct. And we should have certain interventions in which these people can walk confidently. And I know there are several interventions which are being talked about, like having a full body jacket on yourself and then people being able to walk with some smart materials which are used in them. So several interventions. Since I also belong to the field of evidence-based medicine and have been working with, in fact, Australasian Cochrane Center, and it's currently the evidence synthesis unit being led by Stanley Green. I'm actually lead for Cochrane India here, and we also establishing an evidence synthesis unit with Cochrane collaboration. And so we really need to see all these interventions which are there, which are really going fast, how effective they are and how cost effective they are, how accessible, how equitable they are, how ethical they are. So I think we need to apply that equity lens to all the interventions, and I think that is what the future will decide, that this evidence-based medicine should become value-based medicine and work with these organizations.
Aman, I'm going to come to you now.
Sure.
Could you please elaborate as to what are your aspirations? If you represent yourself and a large number of people who need these platforms to be really user-friendly and also inclusive. So what are some of those aspirations from your perspective? I've twisted the question slightly. Maybe you can just give us your perspective, personal and collectively.
So, greetings everybody. My first interaction with virtual healthcare really started when my dad was discovered with chronic kidney disease. And ever since I looked at virtual healthcare delivery systems, including eSurgery and others, I personally felt that platforms such as these have immense potential to change how these services can be delivered to people with disabilities. And I'll just give you a couple of thoughts and examples of what can be done and what is it that we would really want to see. In a conventional system, when we go to a hospital today or a healthcare facility today, there are certain steps involved, which is first is the manual filling of form, visiting from point A to point B, where you don't know what the navigation is going to be like, etc. And then being able to communicate with the doctor in the language that they understand and that you understand, right? So which assumes certain things, your speech clarity, because doctor may not know sign language, or the prescriptions that they write then becomes inaccessible for you if you're visually impaired, so on and so forth. But if you now look at a virtual healthcare delivery system, all of this can be transformed if we take care of 4 aspects. One is accessibility of the entire platform, and accessibility not just from a technology perspective. Technologically making the platform accessible is one thing, but giving them the flexibility to the user to be able to operate and use the platform the way they want it. So for instance, if I don't want to speak, but instead type, because I personally prefer typing more than speaking, assuming, then it becomes easy for me to do on a virtual platform, which in a conventional sense may not be possible. If I need sign language interpretation, there could be a facility of video call sign language interpretation where I, along with my sign language interpreter, can speak with the medical professional on the other hand, or converse with the medical professional on the other hand, and whatever the medical professional kind of communicates can be relayed by the sign language interpreter to me. That solves the problem of a huge segment of persons with disabilities, which is persons with speech and hearing impairment. if a doctor gives me a prescription or prescribes certain medicines, all of that information for which I had to earlier rely on a chemist, etc., can be provided to me in an accessible manner, for which I don't need to depend on anybody. I simply can log on to any of the websites that deliver medicines and can order on my own independently, right? If I go to a physical healthcare delivery system provider, then where to sit? How do I position myself so that I'm facing the doctor? I'm specifically talking from a kindness perspective in this case specifically. Whether what I'm saying, doctor is able to pay focus to it or not, or doctor is looking at somebody, some report or some paper for that duration and should not be speaking. All those challenges honestly can be overcome with the virtual healthcare delivery system, because you will have AI guiding you how to align your camera, whether you're positioned perfectly or not, and when you need to pause, when you need to start, etc. So virtual healthcare delivery system can really transform the way people with disabilities experience healthcare, both right at the stage of diagnosis, preventive care, as my other co-panelists spoke about, etc., and even innovate to make sure that it reaches. Like e-Sanjeevani, I personally feel it's an innovation of its own kind, because in India, as people say that the tech literacy has been low in past few years, although it has increased over a period of time. But having a system where you could just dial the system and healthcare would be at your fingertips, I think it's quite remarkable. So that's what I would think where virtual healthcare delivery system can move going forward.
Take your opportunity, and where do you think the future lies if we were to make health delivered through platforms such as e-Sanjeevani or similar telehealth platforms? What would the future look like?
First of all, I would like to thank Dr. Nader and Dr. Emma George inviting me for the VirtuCare program. Before the COVID itself, a lot of medicine and tele-rehab was happening in Kerala. Dr. Mohammed actually is here, and he was director of executive director of NIPMR and also Social Security Mission in Kerala. So what I could understand is, like, because of the COVID, many people with disability, especially I am working with children with disability, many parents, they were unable to bring the children to the therapy centers. But in my practice, we were empowering the parents, we were including the parents for the therapy from the beginning. So during the pandemic, or whenever we have a flood or whenever we have a landslide issues in Kerala, they are able to manage the children at home. And after the COVID, what I could see is, like, the busy practitioners or people who doesn't have access to certain professions, they were able to access them with the telemedicine. So the future is, like, in our association, our All India Occupational Therapy Association, during the COVID itself, we had conducted a tele-rehab module. More than 300 occupational therapists got certified in this, so they are able to do the practice. But only thing is, there are a lot of stigma about tele-rehab. Some people are concerned about the privacy. Some people are, in Kerala, the Kerala government has introduced a program called Care Phone. 140 rupees per month, we can access the internet. So a lot of people, I think in future they'll be able to access the internet in our place, because internet accessibility, like the coverage, the network issues is more. So we need to have more connectivity. So that is one part. I think we should in future we should the coverage, the network is very important. And another thing is, like, many occupational therapists after the COVID from Australia, US, Canada, they used to send us email like, is there any regulation or practice for tele-rehab in India? So because it should be ethical. Many people, they do consultation. We don't know whether they are qualified or not. So regulation of practice is another challenge in our country. So that also needs to be taken care of it. when he was talking about the AI, like there is National Institute of Speech and Hearing in Toronto. They have a lot of like assistive devices, a lot of programs for people with visually impaired and speech and hearing. So a lot of programs happening in Niche in Toronto.
Thank you, Joseph. Thank you. Dr. Vinu, I'm going to come back to you. Amar mentioned something like, how do we help people, not only with disabilities, even our populations who are accessing care at tertiary center, like the ones that you head one now. Is there an opportunity to use platforms like Isanjeevani, or even before that, someone who is capturing the history in a concise manner, either over voice, and then making that available for the practice of health delivery, either a virtual consult or an in-person consult, and also to ensure a continuity of care. I'm pivoting a bit so that we see where future of Isanjeevani might head like, or inclusion in the broader sense of inclusion could be. So taking on from the cues that Amar has given us on how can we make our practice a little more inclusive, not just including for people with disabilities alone.
Yes, I think scaling up of all these interventions is very important. Although Isanjeevani has done a lot of coverage, but I still feel that we need to have to and fro consultations between patients and doctors in all the institutions. Government of India has actually started a project called National Medical Colleges Network. And that National Medical Colleges Network has a big network of medical colleges as well as what are known as regional resource centers. And all these institutions have been equipped with hardware and software, which is good enough for establishing connection with the community. Not only with the community, but also with medical professionals. For example, in Isanjeevani also, we have Isanjeevani Super Speciality, we have Isanjeevani OPD, we have Isanjeevani AB, that is Ayushman Bharat, the one which is used in Arogya Mandirs, the health and wellness centers which was known earlier. So, if we use this platform alone, which itself is very robust, and it is they're finding new ways of its becoming usable for people from different walks of life. So that is one thing which should be adopted by all these medical colleges and the various medical institutes which are there, private as well as government. I don't know how much is the adoption by private medical colleges of Isanjeevani, because that is something which they've always been asking for. Even earlier when National Knowledge Network was, the bandwidth were distributed, somehow the private institutions were not there. And we know that there are very strong networks like Apollo Network, which is there and providing healthcare through telemedicine to various localities. But mostly these were for finding cases. But then we have Arvinda Eye Care, which is going on in South, and they do such a good work in providing. Then we had Shankar Netralaya. They started telemedicine networks. So it has to come up in government as well as in private sector. And because India's healthcare, about more than 50-60% is in the hands of private practitioners. And hence, we must enable those people also through, various networks to become involved in this. And as you know, there is a whole lot of economics involved in this. And a lot of people would charge their patients, whereas Isanjeevani is free. And that is one very big advantage that we have. And all the network of, these 4G, 5G, which has come up. And it's become so much easier to do video conference on various modalities, including Isanjeevani, so that, for example, we have a center, a telemedicine center, and we do a teleconsultation clinic actually with Labasna, this Lal Bahadur Shastri Academy for IS officers in Missouri. They set up a rural center, and it was inaugurated by our Honorable President. And what we find there also, sometimes there is a network problem. Sometimes the patients are not able to follow the language. So there are several issues which are there, which can always be ironed out, and ultimately they do get some care. And those follow-up clinics, we have started some follow-up clinics, which once the patients are discharged, we don't call them back to hospital. We just give them care in home. And recently we had this mishap in, there was a Silkyara tunnel collapse, in which the tunnel collapsed and there were some 40 workers who were trapped there. So they came back to in Rishikesh. We established a telemedicine consultation with them. They were very reassured. And when they came out, of course, they were quite healthy, but it was only one of them who had some heart problem and she was taken care of. But in their follow-up, they did have certain problems. And those problems are not only health problems, they have other problems also, like employment problem and economic problems, nutrition, all these things have to be advised. So follow-up of these patients is a very good, intervention which can be done for all walks of life, of all kind of patients, whether they're diabetes, hypertension, all non-communicable diseases, accident survivors, because they also need to be told what is to be done, neurological disorders, their continuity of care is so much important, especially for disability. It is so important to reinforce what the kind of exercises, interventions, which they have to do at home, and for which, they need to be motivated, the attendance of the patients. And there are certain apps which have been developed for them by my previous institution, which was PGI Chandigarh, and we are using them in Rishikesh as well, where their patients' attendants can be motivated to take care of their disabled, wards whom they are looking after. So anything.
Amar, I'm going to come to you. If there is one change that you want to see in how healthcare is delivered, and you did mention a number of things, can we have AI/ML into the whole consultation conversation itself for the doctor to be nudged into giving responsive consultation, and how for you as someone who's accessing that care can also pace yourself during the consultation. But if you were to ask for one change that you want to see in being inclusive health services delivery through the platform as well as beyond that, what would that be?
Since the question is broad, I'll take liberty to answer it broadly. Each touch point of the healthcare delivery system, if that can be looked at it from a perspective of inclusion and disability and accessibility, awareness and training. If we can have all these components into each touch point of healthcare delivery, I think it is going to make a big change. So even when the doctor knows that my next patient is a patient with disability, if the doctor gets a short 1-minute video before the patient is with the doctor to see how doctor can communicate better with such a patient, what they need to know, what the patient need to know, etc. All of these things, very small gestures, but these can go a long way in making sure that the entire ecosystem becomes more inclusive and accessible.
Thank you, Amar. Sunny, we hear so much about emerging technologies and all of this. Do you think that this technology is really going to make a difference, or it is a lot of hype? What is the pragmatism that you bring to the table? Because you work with young children and trying to help them be back and as full as possible in living lives, actively contributing to society. So where does technology and technological optimism and pragmatism come to the meeting point?
Yeah, see, when I work with children with disabilities, for example, when a clinical psychologist, when they do an IQ test, certain areas, certain assessment, certain physical assessment, we may not be able to do with the telemedicine. And as I mentioned earlier, there is a lot of stigma, like still even the medical practitioners, even the rehab professionals, they feel that the technology, the telemedicine is still not not up to the mark. So we have a lot of studies to the advancement of telemedicine, and even certain schools, certain colleges, they have included telemedicine in their curriculum. So my advice is like each UGC itself or in the medical college itself, we should have a telemedicine in our curriculum. and some of the occupational therapy and other rehab professionals, they were doing internship online. Psychologists also did internship online. So there are a lot of scope in doing online tele-rehab, telemedicine, and even the internship opportunities and observationship can be done through the tele-rehab. So that is what I wanted to update in this.
Can I say something on like AI? Everybody has been talking about AI, artificial intelligence, and we know that it is going to come in future, and we would certainly, solicit help in this field from countries like Australia, because that is where it is being used on a much better platform, on a much higher technological platform. Because telemedicine is fine. These days, every kid is doing telemedicine, for that matter. All the students, they have their mobile phones, and they are doing video consultations. They are talking to their friends. They are counseling people. So now telemedicine is in the hands of every person, anybody who has a smartphone. And from that comes how to solve people's problems on a much faster rate. And that is where these clinical decision support systems, which are based on large number of data sets which are being created, say from ECGP, such huge data set which has been created. And we are looking at forming, for say diagnosis of retinopathy of prematurity, diagnosis of retinopathy of diabetes, hypertension. So how to make that diagnosis as quick as possible. We have dearth of radiologists. We don't have so many of them. We know that AI can solve that problem. So I think we will also have to use AI for constructive use. Of course, it can't solve all our problems. The human touch will still be needed in clinical medicine. When a person talks, when a person talks and when a computer talks, there is a lot of difference, as we have seen. But gradually, I think it is catching up, and people with disability also will find it much easier to access care through these means of artificial intelligence.
Thank you, Dr. Meenu, for that. I just want to jump in here and maybe suggest something that is provocative. What if we could incorporate within eSanjeevani a mechanism to detect whether quality of consult for someone who with disability is slightly different or inferior to that with someone who is doing the consultation? Could we use algorithms to nudge that early on in the consultation, that like what Aman mentioned, if you know that, one is that a person with disability is going to have a consult upfront, and you give some sort of an orientation of how that consult needs to be. Second is to actually have a surveillance mechanism by which ongoing quality of consultations and care delivery is monitored, and use those nudges to help us clinicians to provide better care. And with that, I think I will just draw this panel to a close. Thank you everyone for contributing, and hand it over back to our moderators. Thank you so much.
Panelists and to our moderator for that intellectually stimulating panel. Lots of ideas came up to follow up, and of course lots of issues were also discussed, and something for us to think about and take forward in our future discussions. I would now like to introduce Sri Rajesh Agarwal, who will be giving us his reflections on the proceedings today. Sri Rajesh Agarwal is the Secretary of the Department of Empowerment of Persons within the Indian Ministry of Social Justice and Empowerment, having been in this role since September 2022. He has previously served, amongst several other governmental positions, as the IT Secretary of Maharashtra 2011 to 2015, and the Secretary of the Ministry of Skills Development and Entrepreneurship from 2021-2022. His department has been a close collaborator with the University of Melbourne under the Australia-India bilateral MOU on disability. I warmly welcome Sri Rajesh Agarwal to the stage, please.
Good day, everyone. It's been interesting to listen to the panelists and the speakers before that. I have been in this sector only for 2 years. Many of you have spent much more time than me in this sector. And what I believe is that this is a special kind of sector where government working alone through regular government systems, schemes or infrastructure, that's not at all enough. This is a sector which needs professionals but with passion. So both things are needed. So that's why I was happy to see that this project had a lot of partners. So in the network you obviously have to have persons with disabilities, their parents involved, the doctors, pediatricians, then special educators, normal school educators, then lowest level workers like ASHA workers, Anganwadi workers for early detection and early interventions. Then you need people like AIMS and higher level doctors and assistive technology, all the companies working in that, engineers working in that. Ultimately, disability is a very interesting intersection of medicine and engineering. So you need all kind of people to really network with each other. You need corporate support, CSR support. A lot of philanthropy flows into this sector. So this is one sector where government spends much less than the philanthropy and corporate sector. And that's the right thing also, because ultimately passion works much more than government systems, as I said. We just have to be a good regulator and facilitator. So Dr. Meenu was talking about prevention. So I am in Maharashtra cadre. So long back in Maharashtra we used to have a landline so that pregnant ladies could actually ring up that number, missed call bhi de sakti thi. And they would say ki what month of pregnancy is going on. Then every week you would get a call, 2-3 minute ka call, you could listen to those calls, that in this week please focus on these things, on the eating, on the exercise and so on. Now obviously we have WhatsApp kind of systems, but these kind of systems help. And COVID obviously changed the whole online game. COVID told us that online teaching, online education, online work, sitting at home, online health, getting online prescription from doctors and getting the medicines delivered at home. So it changed the attitudes of people, and it also changed the regulatory frameworks, whether it was education or Factory Act or the health systems. So now COVID is over, but a lot of good practices of online learning, prescription, etc., they continue. So there was some talk of one. I must appreciate AIMS Rishikesh. Though we were in talks with AIMS Delhi for more than a year regarding setting up LMCO center there, but Rishikesh became the first one to sign an MOU with the LMCO. So the whole idea is that just like we go to AIMS or any government hospital, they diagnose us, they give us some free medicines, or they say free medicines you'll get after 2 days. Or we can just walk outside, there is a chemist, and we get the medicines, we purchase the medicines immediately. But in the disability sector, if a doctor says you need a wheelchair or you need prosthetics, earlier we used to say कि assessment कर लेंगे, फिर 6 महीने बाद कैंप लगेगा आपके यहाँ पे, 1 साल बाद लगेगा, you will get the prosthetics after 6 months or 1 year. So just like medicine, if the doctor at AIMS says you need a wheelchair, there should be an LMCO center which we now call the Vyasha Center. If you are eligible, you should get it free. If you are not eligible, you can pay for it and get it there and then. So immediate delivery. And if it is customized thing like prosthetics, a socket has to be made, or anything else similar, so orthotics, etc. for children. So again, you should not have to wait 2-3 months. Then it should be a 2-3-4 days affair there. So that's the whole aspect of working with a lot of government hospitals and trying to setting up LMCO centers there. And we started 6 months ago. Today we have 46 Divyasha Kendras, and already the distribution of more than 50 crores rupees has happened from there. That is free distribution. But we will be opening it for purchases also to those people who are not eligible for that or who want to purchase a better model. Let us say I am giving a hearing aid free at 3,000 rupees model. If someone says, no, I want 20,000 rupees model, that should also be available there and then. So that's the broad idea there. eSanjeevani, I'm happy to see the data, but obviously we really need to scale it up. At Sundarnagar CRC in Himachal, I saw my own physiotherapist actually doing a tele-physiotherapy with CP children, with stroke patients, with old people. So in hilly areas, many people can't come. There are a lot of rainy days and mobility issues, etc. So that has become quite popular. So they have a fixed time of 1 hour a day, so people can join in. It can be group kind of physiotherapy or it can be one-to-one, etc. So there is a lot of scope in this. And not only physiotherapy, there is obviously a lot of scope in many other things. During COVID, our helpline Kiran became quite famous. Then Telemanas of Health Ministry is quite famous. Though it's more for getting psychological kind of help, getting counseling. So now that is also happening quite a bit. Now almost every company, every big company, whether it's Google or anyone else, they do have psychologists on board, and any employee who is under stress, they can ring up that psychology on audio. They do get sort of telehelp. So the whole attitude and regulations are obviously changing. On the extreme end, we have now surgeons in China actually using robots doing surgeries 4,000 kilometers away. The surgeon is sitting 4,000 kilometers away and the robot is doing the very well managed surgery. So that's the other end of telemedicine. Now AI applications, for example, in derma, they are coming up, that you can click a photo of your skin patch and either the AI on your mobile will help, 90% yes, this is the skin disease and this is the ointment you can take, and it's actually pretty nice. Or you can then consult a proper dermatologist. So the AI app suggests 90% chance is this, otherwise these are the nearby dermatologist in your district, and you can approach them, or you can even teleconsult them. So a lot of Practo and other apps are actually moving towards that also. So the Divyang Mitra kind of thing with the Melbourne University's help, so that course has come up quite well. So 10th, 12th pass kids in villages, they are doing this 3-month online, offline kind of course with us, coupled with 3 months of internship. And then they are like low-level health workers for us. Community help also, getting the people knowledge about the schemes of the government which can help them, getting them to get into schools. And telemedicine is actually quite effective, where Dr. Minu was also mentioning that at Ayushman centers, health and wellness centers at taluka levels, one can go there, there will be local nurse, a plain kind of doctor, and then if the patient needs more help, then you can consult a specialist over telesystems. So the similar kind of thing for CBID, yes, we should try to plug it in, and we'll be happy to work with eSanjeevani on one is obviously Rahul and Amar, ये सबके पीछे लग जाते हैं, और एक बार अमर या राहुल पीछे लग गए वो छोड़ते नहीं हैं. They will make sure you are 100%. Till then they will keep on harassing you. That is their USP. That's what actually is needed in the sector. Dr. Stender also, he will keep on fighting. And unfortunately, that's what is needed in the sector. The sector is otherwise too resistant. By sector, I mean the whole society, not only the government in this case. The attitudes also are hard to change. So that's why this sector needs more fighters, and from the community itself. And for example, we have a helpline 14456. It's a normal audio helpline. Then the deaf community said, what about us? We can't hear. So we asked a company called Signable to provide us the digit window. So you can actually now, rather than dialing 14456, there is a QR code. You scan that QR code on your mobile. A sign language interpreter will come up. Then he or she will ring up 14456 or anything else, and they act as intermediate. So we'll be very happy to plug in that video relay service for deaf people in eSanjeevani and actually run this in 2-3 deaf schools so that we see how it works, how the doctors react, how the deaf persons react. One more point from my side. We have now anonymized disability data. I have about 1.25 crore UDID at the moment, the disability cards. So we have done anonymized data aggregation at district level. So you can go to our website depwd.gov.in. You can go to aggregated data tab. So you will see district wise, 21 disability wise, gender wise, and age grouping wise, 0 to 6, 6 to 15, etc. The numbers, the male female numbers. So you will see that in Jhansi or in Rishikesh district, in the 0 to 6 category, so many girls with low vision are there. So you can see that data and you can see how the patterns change. For example, near Kanpur where the tanneries are, the ID ratio is more. So one can actually see patterns in the data. We can see which disabilities are going down. For example, CP is going down because of polio is almost over. CP is going down due to institutional deliveries, but unfortunately the accidents going up. The amputations of foot due to diabetics, these are going up. So when we get data from Jaipur Foot and from Olimpo, the cases of amputation due to diabetes, due to accidents, they are up. So that data is very useful. So from research point of view, anyone who is doing research in the disability sector, to the doctors, to the even companies that where they should try to sell their products, assistive technology products. So this data is very useful. So yeah, we would love to work with anyone who would like to work with us, and this is a sector where working together will only help. Thank you so much.
Thank you, Sri Rajesh Agarwal, for the summary and the many ideas you've put in our heads for more work. I would now like to introduce the Honourable Lisa Singh, who will be giving a vote of thanks closing today's plenary. The Honourable Lisa Singh is the current CEO of the Australia-India Institute at the University of Melbourne, a leading research and policy think tank advancing Australia-India relations. Notably, she was the first woman of South Asian descent to be elected to the Australian Parliament, serving as a senator from 2010 to 2019. In recognition of her role in advancing Australia-India relations, she was awarded the Pravasi Bharatiya Samman by the President of India in 2014, the highest civilian honour for overseas Indians. The Australia-India Institute has been a key partner of the VirtuCare project and published a report on VirtuCare's progress in 2023. And now, without any further delay, let me welcome the Honourable Lisa Singh to give today's vote of thanks and to close our plenary.
Thank you very much, Emma, and it's wonderful to be here in this global centre of the University of Melbourne for its second event, and I'm sure you'll join me in agreeing that the second event has been incredibly impactful and is a sign of really good things to come for the university and its relationship with India and all of its people into the future when we hear from so many experts like we've heard this morning. And I think that's where I'd like to start, firstly by also just noting our partners that have made today possible. AsiaLink, thank you so much. I'm a board member of AsiaLink, so I'm slightly biased in their work, but for the Institute to partner with AsiaLink has been very good. I really just want to start though, before I give a very big vote of thanks to recognise the experts that have shared with us today, and also all the collaborators that have made this particular program possible, sharing so much depth that goes into this program. I have certainly learnt a lot. I learned a lot the last time I engaged on VirtuCare when we launched the report, which by the way is available on the Australia India Institute's website. But I've learned a lot more again today. Every time I engage with experts in the disability inclusive space, I do learn, and I think that for me is very impactful for the work I do leading a think tank that wants to have a closer engagement with India on a range of social and economic and political issues that our two countries can work more closely on. I think just some of the takeaways I want to share personally for me today were about disability inclusive consultations, the importance of them, the importance of ethical consultations, the importance of evidence-based medicine to be values-based medicine, were real highlights that I will take home, literally home, because I'm the mother of a med student and who's in his last year. So, but I really want to just highlight the fact that the Institute has long supported VirtuCare, especially though under the leadership of Professor Nathan Grills. And Nathan, of course, is an academic fellow with the Institute. He's a senior advisor with the Institute. He's passionate about this space, and the insights on virtual healthcare that he shares with us at the Institute in University of Melbourne, but in Australia, are really quite unparalleled. In terms of the Towards an Inclusive Future report that's on our website, it really highlighted the economic benefits of investing in people with disability in both India and Australia, and how transformative that can be. I think we heard a little bit today about the impact during COVID, and how the findings of this VirtuCare project in 2024 showed that whilst COVID pandemic did have extreme impacts on the delivery of healthcare in India, it also had unexpected success stories. And the role of telehealth in both countries now is one of those success stories. And as Sri Agarwal said, good practices of online learning continue now. And I think that is something we can take away out of something bad. Something good has come. The immense benefits of this platform, I think, cannot be underestimated. So with that, it gives me pleasure to give a vote of thanks firstly to Professor Michael Wesley, who opened today's proceedings, the Deputy Vice-Chancellor, Global Cultural Engagement at the University of Melbourne, who's been a driving force, of course, for this centre to be open for us to be here. To Minister Councillor Carly Partridge from the Australian High Commission here in Delhi, to Professor G.V.S. Murthy, President of the Pragyan Sustainable Health Outcomes Foundation, to Dr. Shailaja Tatali, the Professor and Dean of Research and Policy Support at the Indian Institute of Public Health, and of course to also acknowledge Sri Rajesh Agarwal for giving his summary on the impact of this project so eloquently and sincerely. Of course, Sri Agarwal is IAS Secretary, Department of Empowerment of Persons with Disabilities, Ministry of Social Justice and Empowerment, Government of India. And I've always said that Australia should have a Ministry of Social Empowerment and Social Justice and Empowerment. To Mohammed Amil from the World Health Organization Regional Office of Southeast Asia, and to Dr. Mohammed Ashil from the World Health Organization Country Office in India. And very special thanks to our panelists, moderated by Dr. Umen John. Can I thank Dr. Sanjay Sood, Dr. Amar Jain, Dr. Rajendra Pratap Gupta, and Dr. Meena Singh. Thank you all for your insights, and thank you very much to Professor Nathan Grills for your insights and leadership on such an important area of research and study that I look forward to continuing to be a part of as part of our institute and watch in time to come. So on that note, I'd like to thank you all for coming, formally close today's proceedings before we have some lunch, and ask our speakers and panellists to come onto the stage for a group photo. Thank you.